This podcast is brought to you in association with ANZ Hernia Society, the International Hernia Collaboration, the Abdominal Wall Reconstruction Surgeons Community, Melbourne University, and is now endorsed by General Surgeons Australia. Good evening, and welcome back to the Hernia Hub. In episode 5, we will explore the crossover between AWR and plastic surgery, and try and make sense of terms like Batunge, fleur-de-lis, and Neoumbilicus. To assist me in this endeavour, as always, is my co-host, Ramana. Welcome back.
Hello.
You've braced a smattering of terrible Victorian weather. Are you feeling homesick yet?
No, I'm good. It's not very cold at all. Double-digit weather is fine.
That's good to hear. Our guests today join us from near and far. They've made their names as the finest exponents in the craft of AWR. Welcome to the Hernia Hub, Kellee Slater from Brisbane and David Roach from London. Thank you both for joining us.
Good evening.
Thank you. Morning from London.
Kellee, apart from the accolades you've earned through your work in surgery, you're also a very successful YouTuber. Can I ask you if you think this is the ultimate medium in education going further into the 21st century?
Yes, no, completely. I bumped into a cardiologist in the elevators yesterday that I had never met before who had viewed me for my videos, and he said, isn't it amazing the way we learn with YouTube now? And I actually, for the first time, don't have any qualms in telling patients when they ask me where did I learn, I often say from YouTube, because isn't that where we all learn to do everything now?
Increasingly so. And David, thank you for joining us from London. I know it's early in the morning there. It's a real pleasure to welcome another Englishman to the Hernia Hub. You convene one of the most important AWR conferences in the world in AWR Europe. Can you tell us a little bit about yourself?
I'm a plastic surgeon. I trained UCL in London in the mid-80s, and then my primary focus of reconstructive work was post-cancer reconstruction. And for just under 25 years, I was a consultant at St Thomas's in London, which is a very big teaching hospital. And we built a very big cancer recon department, primarily involved with micro. But as a consequence of the relationships that we built up with our general surgical colleagues and our gynae oncology colleagues, we also got involved in a huge amount of complex perineal and abdominal wall recon. And so that eventually began to take over my practice. And here we are at the present day. 10 years ago, we started the Abdominal Wall Recon Europe conference in London, myself and Al Windsor, who's another very well-known colorectal surgeon involved in abdominal wall work, primarily because at that stage, we were starting to see quite a lot of interesting cases being referred to Al, which reflected probably not the best technical judgment at the time. And it was a question of how we could realign people's thoughts to timing their reconstructions and their reconstructive choice. And as you know, this field has grown dramatically in this last decade, really dramatically. And like Kellee, like Ram, I've had the opportunity to travel around the world learning new techniques, but also just seeing exactly how this Cinderella subject has become really one of the most fascinating and important aspects of combined general and plastic surgery.
All right. So to continue on the same lines as the first couple of minutes that we've had so far, let me ask Kellee, in the field of abdominal wall, are you interested in everything hernia, or do you have any special subjects within it that you're particularly interested in?
I think everything hernia, similar to David, it takes over your life. It becomes an addiction, I would say, abdominal wall, to the point where it's all you can think about sometimes, which is very strange, but it's so rewarding. Almost everything. I mean, as you know, there are the robot doctors amongst us and the open doctors amongst us, and sometimes the laparoscopic, and I definitely tend towards open surgery because for reasons we'll get into in this podcast, and because of my background in open hepatobiliary surgery. But there's not many hernias I don't dislike.
And for most people who may not know it, she is or was a celebrated transplant surgeon. Am I right?
I was. And I think that hernia is more difficult than transplant, to be honest. And but it's true. So I think transplants trained me to be good at very difficult hernias and look after very sick people. So I think transplant is the fellowship that you do before hernia. That's what I think.
Incredible. So, talking of passion, AWR work is back breaking, shoulder raking, and disc blowing. Do you think that there is any kind of practicality when it comes to a professional practice? In the sense, every professional works by the minute or the hour and gets paid according to the hours they put in and according to the skills and efforts that are needed in that particular craft. Whether it's a pilot or whether it's an space engineer or something, there must be some kind of correlation between what you put in and what you get out of it in order to sustain your livelihood, and which is, I assume, for most people, it is a matter of livelihood. And if it is not, that's a fantastic thing, which I think is the ideal way. But again, to come back to the question, that is there any element of practicality in what we do? Is it all passion and financial aspects are merely side effects which one needs to look aside because they are pretty miserable? How do you look at it?
Well, I don't think any of us would get out of bed if it was just the money that was driving us with this. The money is very nice and obviously feeds our family and gives us nice holidays when we get them. But for sure it's passion. And I'd like to think that the remuneration for hernia in Australia has significantly improved in recent times with the rewriting of the NBS item numbers for us here. But I think as in general surgeons have been quite poor at standing up for themselves in those item numbers departments. And I think that's changing as we're all learning how that system works a little bit better. So, but I mean, the long answer to your question is that I think it is 70% passion, 30% financial. So that's my take.
Dave?
Well, I think we have a very different system here in the UK. So in the NHS, of course, where I did most of my very large cases, you're on a fixed fee. There is no association between what you do and what you earn. You're on a fixed salary per year. If you do this work in the private sector, as I do, the insurers still don't recognise there is not a great financial incentive to do any of these cases. But the driver from it comes from the fact that they're, first of all, very challenging. They're technically demanding. The patients are hugely in need. So you have multiple clinical and philosophical challenges facing you when you deal with these patients. And one of the things that's really struck me over the last sort of 20 years of my developing interest in this field is that our technical range of work that we can offer the patient, of course, is now extended from open through to laparoscopic through to robotic. But actually the real innovations and the real challenges have come in managing the patients prior to surgery. So the whole art of prehabilitation. So when you see a patient coming into your clinic for the first time, you're contemplating why have they developed a hernia? What lies behind the etiology of their problem? Whether it happens to be diabetes, whether it happens to be post-operative complication, whether it happens to be poor technical choices. And this is one of the things that led to the development of AWRE in the first place. That I, as a plastic surgeon, was seeing a fairly steady range of patients who were coming through who, in my mind, had had inappropriate surgery. So, for example, I will tell you one of the first cases. So I'm going back to the mid-noughties, where I was asked to see a patient. He was 180 on kilos. He was a huge man, but he had a large ventral hernia. And at that stage, equipped with a mesh, his general surgeon felt that this was operable. And of course, it was quite easy to make the incision, but to close the wound thereafterwards became more challenging. And this gentleman ended up with really very lengthy, complicated wound complications, including large fistulation, which is where I got involved in. And I started to see a number of these cases at that stage. So the drivers really are about patient selection now. So all of us, when we're faced with these patients, technically we have the armamentarium, but the question is about patient selection. And I think, so that's the first thing that I think that's challenging and interesting about these cases. And as I say, in the UK, I'm afraid finance is not a driver we can even think about. It's of no relevance, to be honest, either privately or in the national health sector. But there is something else as well, which, as I say, the patients themselves are presenting with problems which centre around this most core, unrecognised aspect of the human form, which is the abdomen. And when you look back historic at the understanding and the appreciation of the abdomen, both in classical are, and I'm talking about going back way pre-Greek periods, when you think about the way the abdomen was revered, was observed, and the importance that was attached to it, both in terms of possible fertility, in terms of strength and wisdom in the Greeks, and then how we then evaluated what we regarded as being aesthetic right up to the modern day. It is a most fascinating area of surgical interest, both from the person right the way through to the actual technical exercise. A long answer encompasses why we all find this field so utterly fascinating. And last but not least, when you look at your generation, Ram, Kellee's and mine, the fact is we are looking at the next generation coming along with the use of robotics and AI, and they are already being applied to abdominal wall. And I think that's utterly fascinating. We may not be able to be part of it, but as surgeons, we're enthusiasts by definition. And so to be able to observe the implications and the applications of these novel treatments is absolutely amazing. And in the last 3 Abdominal Wall Europe conferences, we have had sessions on the role of AI. And of course, we've been watching it evolve very rapidly. And, you know, it's here. And how we apply it may not affect the way the 3 of us work. It will certainly affect the way Roshan works. It will certainly affect the way other young trainees work. And it'll have a huge impact on medical care in general. So I think, you know, abdominal wall acts as a sort of focus, a lens through which we look at every aspect of the patient journey.
There are many things I would like to take off from there, including whether surgery itself should become a source of engagement, entertainment, or excitement for a surgeon, because the more exciting it is for the surgeon, the worse it is for the patients. So I often wondered how many complications I've created because I was excited to do the surgery, the patient wasn't. Well, anyhow, that's different. But let's come back to the abdominal wall. Now, the centerpiece of the abdominal wall for us as surgeons, and definitely for many patients, is the umbilicus. So as a plastic surgeon, Dave, please enlighten us about why the umbilicus is special, if at all, and why is everybody so focused on the umbilicus per se, especially the patients?
Okay, so I think first of all, let's look at the normal abdomen and then move on to pathology. So in the normal abdomen, the umbilicus is an essential focus of our attention. Its position, its location, its shape, and that position and shape will change through life, and it will change through the effects of weight gain, weight loss, and of most importance, pregnancy. So we associate this small but important anatomical structure as an essential part of what makes up the aesthetic appreciation of the abdominal wall. And it's for that reason that I'm always very concerned when I hear my general surgical colleagues talking about amputating the umbilicus and simply discarding it because it facilitates a hernia repair. There are occasions where you have little choice but to do that, particularly in the recurrent patient. But as a general rule, it's very easy to conserve this important anatomical structure. And of most importance, patients like their umbilicuses. They might turn around and say to you, once you said to them, look, I've actually got to take this away, the poor patient's left with no choice. But actually, in many situations, they most certainly are left with a choice. And it comes down to surgical technique. It would be like removing any other part of one's anatomy. While it tends to not be seen, when it is seen, it's important. And of course, again, symbolically, what it represents in terms of it is something that we're all attached to. So it shouldn't be lost easily. There are rare occasions where you amputate, but I have to say, in my practice, that's exceptionally unusual.
Have you seen any interesting pathology other than hernia or a sinus in the umbilicus?
Yeah. So, unfortunately, I've seen melanomas in the umbilicus, and you will see on occasion other skin tumours. And of course, you can see any form of skin pathology. But actually, one of the interesting things, of course, that you see associated with the umbilicus, hernias themselves, either primary or as a consequence of pregnancy or as a consequence of iatrogenic causes, so laparoscopic hernias. You see a range of hernias that occur immediately around the umbilicus in terms of supraumbilical hernias and tears, particularly again post-pregnancy. And then, of course, where you have had patients who've undergone some form of circumferential incision around the umbilicus, say for example at the time of an abdominoplasty or an abdominoplasty approach to reveal the underlying wall, you can get a cicatricial scar, and they're very troublesome. They're really difficult to treat actually, because the umbilicus basically just stenoses, and they can be really, really difficult. In fact, if not impossible to treat.
Many of us have also seen some occasional interesting findings like a Sister Mary Joseph's nodule of malignant deposits, or caput medusae, sinuses, and raspberry tumors. So for those who are younger and watching us or listening to us, these are things which do affect the umbilicus, and it's very, very interesting. When you know it, then you can diagnose it, and then it feels really cool.
Kellee, what would you describe as the principles of abdominoplasty?
Well, I've written down a few of my thoughts about this, and the things that I go through with my patients are the most important things. So for a start, the first thing to ask somebody is what character. I'll make a distinction between, I do abdominoplasty with major ventral hernia, and it's a slightly different conversation than abdominoplasty for patients who've had significant weight loss through bariatric surgery, both of which are big parts of my practice. And I would say I perform abdominoplasty on, I would suggest 85% of my hernia patients. And then I also have the huge part of my practice as the skin contouring patients with weight loss. So slightly different principles, but also similar. So from a technical standpoint, blood supply is everything in abdominoplasty, and you need to be tailoring your incisions and your surgery around a good blood supply for the patients, because necrosis of your flaps it's a devastating complication, and it comes down to the technical. But most importantly, from a patient perspective, is that you have to sit back and ask the patients what they want from a skin reduction operation. How do they feel about their skin? What bothers them about their skin? And I'm not sure sometimes that surgeons sit back and ask patients what they actually want, because many of our skin contouring patients come to us with they've been thinking about it for years, been researching it for years. There's a huge number of online groups for these patients, so they have seen a wide range of incisions and results. So it's just important to sit back and ask them what they would like. There's the other fun conversation. Every single patient, we have a conversation about their umbilicus, whether they want one or not. And I give patients the choice, because they, again, sometimes have very focused ideas about whether they want one or not. Many of the patients who've been morbidly obese have had nothing but problems from their umbilicus, and the last thing they want is to keep their umbilicus. Patients who have been pregnant and have lost their umbilicus through hernia are very keen to have one made again. So again, it's listening to the patient and what they would like. The other big focus of discussion on the groups and with me is about the corners of the wounds and the dog ears and the flattening and where the incisions will go. Lots of, very actually lighthearted and pleasant conversations, which makes a big difference from the cancer practice and the transplant practice that I came from. So, so these are really fun consultations, because people are at the fun part of their journey, getting fixed.
When you talk about abdominoplasty, you're talking about different operations. I think Kellee was alluding to the fact that you're talking about different populations of patients. So in abdominoplasty, we're thinking about three principal groups of patients. But first of all, the majority of my practice are those after postpartum delivery, and their aspirations and their surgical challenges are different from those patients who've undergone significant weight loss. So you then have, in the weight loss group, you then have a group of patients who will, for example, have very, very loose pallus, to those who are actually presenting with a very heavy pallus and are still very overweight. And that group of patients needs to be dealt with. And then you have the third group of patients where you're dealing with men. And let's just leave those aside for 1 second. In the postpartum patient, the first thing that's really important is good clinical diagnosis. I almost never scan my patients. It is about good clinical diagnosis. And the patients are examined in three postures. You examine them standing to look at the skin envelope, and you take the patient on that journey with you, because enlightening the patient to exactly where their pathology lies, they understand the logic and rationale of the operation you're going to offer them. So it's not a question of just simply making the diagnosis and then just say, well, actually, let's just talk about an abdominoplasty. It's actually them being able to understand where their loose skin is, how it sits, how it hangs, and where you need to position your incision. You then lie the patient down, minimal stress to the abdomen so that you can assess any diastasis, any hernias, and then you sit the patient up. And this is the third posture, and this is important because in sitting the patient up, you can then illustrate exactly where their sub-umbilical crease is. Now, the key point about abdominoplasty, in almost all patient groups, is giving them a low skull, particularly in postpartum patients their scar wants to sit well below their underwear. In the slim patient, in the low BMI patient, you have a subset of patients who are very challenging. They tend to be very motivated. They do a lot of exercise, etc. In that group of patients, you have a very, very thin skin envelope. You have limited skin mobility. So in that patient group, you still want to give them a low scar, but you are not going to use the same technique. You're going to lift the abdominal skin up with the umbilicus. It's a technique called floating abdominoplasty. So you have these techniques. And when you come onto the massive weight loss patients, you're then going to be thinking again about low weight scars. Exactly as Kellee says, there may be some of those patients where you preserve the umbilicus or it's not appropriate. And in the very heavy, in that patient group, you may not want to undermine the abdominal flaps particularly. You may want to keep your abdominal elevation more central, so Saldana type technique. And then in the last group of patients, you're talking about paniculectomy. And making that decision about when you undertake a paniculectomy versus an abdominoplasty is extremely important. If your patient is still overweight and they have undergone massive weight loss and their bariatric surgery tells there's nothing further to do, of course, we now live in an age where we can think about the GLP-1 agonist. And of course, they've proven to be fascinating, and I think they will be revolutionary. I've got a whole group of patients now utilising this drug as part of their prehab. That may be a role, but there in that group of patients, you're thinking about paniculectomy. And in the paniculectomy patient, very often their umbilicus sits low within the palace. And sometimes you may feel you have no choice but to amputate the umbilicus. Again, while you don't want to elevate the superior abdominal flap in these patients because of devascularizing the fat, you can actually isolate the umbilicus on a broad pedicle and tunnel it up back through with minimal disturbance to the flap. So again, you can preserve these structures. But Kelly's absolutely right. When you're dealing with these massive weight loss patients, it becomes slightly more challenging. But the key to abdominoplasty is understanding the pathology and making sure that the patients understand exactly what's happened to their skin, what's happened to their abdominal wall. Now, I happen to follow this up. I've got a series of images and I've had animations made, which Rama would have seen. And they're very, very helpful in being able to explain to patients exactly what's going on. Because the key basis of what happens in all of those patients, and particularly the postpartum patient, is that you are seeing panfascial attenuation of the rectus fascia. There's a great obsession about concentrating on the diastasis. But the diastasis is one metric. That's not actually the key aspect. It's the one that we observe and measure. But actually, that's just one metric of several when you're assessing the abdomen, particularly in the postpartum state.
What other did you mean?
So you would be thinking about skin quality. You'd be thinking about exactly where the skin excess is. And crucially, Rama, while you elevate the skin flap from your low incision up to the ziphus sternum, you're going to be thinking about a midline plication of your rectus fascia in order to address your diastasis. But then you have to sit the patient up, because if you think about it, it's what I refer to as the dome concept. If you think about the abdomen as a dome, it expands during pregnancy, it then deflates. As it deflates, the excess that you create isn't just in the vertical plane. It's not just in the vertical orientation. It's also horizontal. And so the simple plication of the midline is fine. But actually, in slimmer patients who may have lost a lot of weight or, for example, have had multiple pregnancies, when you sit those patients up during your operation, you'll then find they have a horizontal or an oblique excess of fascia as well. And so you may have to put in a whole range of additional plications to be able to tighten that fascial envelope. And people, for example, talk about tightening the external obliques. Very unusual to have to do that, but it's been reported. The same principle. You're basically trying to take in laxity, which is not confined to the midline of the diastasis. So it's about conceptually contemplating all elements of the abdominal wall and how they've been stretched and attenuated.
Right. So when you recite an umbilicus in a patient, what exactly would you look at in terms of a perfect location for the umbilicus? It would be different in me and different in a 25-year-old young lady or somebody else.
So the actual position of the umbilicus on the abdominal wall, apart from moving left to right, the actual position in terms of height and its relation to the ziphus sternum is actually remarkably constant. And so when you elevate an abdominoplasty flap, remember what you're doing. You're making a low, wide incision. You're then dissecting your fat layer just above the fascia, leaving a fatty layer. And as you get to the umbilical stalk, you will then encircle around the umbilical stalk, leaving the umbilicus inside you. You then continue your dissection north up to the xiphisternum, and depending on the habitus of the patient, more laterally over the subcostal margin. So your umbilicus stays exactly where it should be. The challenge comes in making sure that you don't deviate as you plicate the rectus fascia. You don't deviate the umbilicus from right to left. And that's a very common complication. My fellow recently, Ayush, was telling me that apparently only just over 1% of umbilicuses remain central. So it's a marked challenge to be able to maintain your umbilicus exactly in the middle. And there are little tricks to that, which I can share with you. So the position of the umbilicus in terms of its height is constant, relatively constant. In terms of moving it laterally, that's where it becomes a challenge.
No, I meant in terms of its longitudinal alignment between the xiphoid and the pubis. Now that the patient has a pannus and it's completely flopped down, how do you recite it?
Thank you. Okay. So you look at the relationship to the anterior superior iliac spine. Okay. So when the patient is standing in front of you, if you can palpate the ASIS on either side, you can simply just draw a horizontal across and literally just 2 centimeters above. You can position your...
That's exactly what I wanted to ask you. Now, one related question is a patient with either a long-standing primary umbilical or it's a recurrent incisional has a thin, blown-out umbilicus, very, very thin, atrophic red skin.
Yeah.
Now, obviously, it's not looking good, and you as a surgeon know that you have to do something to make it look normal. You can't just leave it like that. Generally, I mean, aside from whatever special experience and knowledge that you bring to your patients, what would you say should be a general surgeon's approach to that kind of umbilicus?
Well, I think just right from the beginning, I think, Rami, you've raised just a really important point here. Okay? As a plastic surgeon, we're used to working with our general surgeon colleagues all the time. And we're there to help and empower them to do their job. And so I think teamwork, and if you have a challenging case, work with your plastic surgery colleagues, because they will always bring something to the game. I have always enjoyed working as part of a team. And you mentioned in one of your earlier questions about the stresses involved with this form of surgery and excitement. Well, none of us want to have excitement, actually. None of us want to have excitement. You want to be in a situation where you're thinking, great, I've avoided enterotomies, I haven't had any other complications. And you got out safely and you can then think about getting the patient recovered. So multiple heads are better than one. In the umbilicus, that thin skin that you mentioned. So when I'm operating on umbilical hernias, and I should preface this, Kellee would have had experience dealing with a really complicated, massive umbilical hernias. The patient having liver failure prior to transplant. I don't ever see any of those patients. They're dealt with by my hepatobiliary colleague. But as a general rule, those primary and secondary umbilical hernias, even with thin skin on it, if they have been stretched, by definition, they've been expanded. So you have more skin than you need. So that's the first thing. Secondly, I operate on all, and I've had no indication in this last 30 years to do it the other way. I operate on all of my umbilical hernias from within the umbilicus. I have no scars extending outside the umbilicus. So I make a little intra-umbilical incision between 3 o'clock and 9 o'clock, elevate the skin flap, even if it's thin and reddened and stretched, identify the neck, reduce the hernia, close the opening, and then that lovely stretched thin skin that you've got will now be surplus to requirements, and you can inset your little flap, remove some of the redundant skin, and close it tension-free. So that stretched thin skin is still nevertheless largely viable, but it will be access to requirements. But you should really, I suspect Kelly's got a different view on that because she will be dealing with much more complicated umbilical hernias. But for example, where we have cases which are recurrent, in those patients, usually, as you well know, they're dealing with much, much larger defects, much larger. They may be 10, 15 centimeter defects. And in that situation, I will do a low abdominoplasty incision, elevate the whole abdominal wall and repair the defect and then relay the abdominal skin.
Okay, you want to add something to that?
Yes, my patient cohort have usually either lost their umbilicus or had one so deformed that it's not possible that it even looks like the original. So, I do a huge number of neoumbilicuses if I'm feeling artistic, especially if the operation's gone well at the end. And part of my thing is to return these patients to a good quality of life. And that includes making them look close to the way they were before these terrible things happened to them. So neoumbilicus is the workhorse of my practice. And the only tricky thing I find is in male abdomens that are hairy, sometimes making those Neoumbilicus is a problem because the hair gets buried down and they get foreign body reactions deep. So the hairy abdomen is probably the only impediment to Neoumbilicus, in my opinion.
And since you raised that topic, how exactly or broadly, how would you create a Neoumbilicus?
Well, it's different depending on whether you have done a low abdominal incision, a Patangi operation, or a fleur-de-lis. The fleur-de-lis is the most simple in that I use a pumpkin technique, bring the tabs down, and it makes a really nice umbilicus. And in fact, patients always comment that it looks better than their original. They also complain that they have to clean it out just as much as they had to the original. I always think that's a bit of a triumph if they have to clean it out just like their original one. So that is a very simple technique to use at the end of a very long operation. Then for Patangi, my approach is slightly different because to David, for the most part, I tend to really dislike the periumbilical scar of leaving the patient's natural umbilicus there. I think it's a bit telling sometimes that they've actually had an abdominoplasty. So I tend to defat the abdominal wall over the point, and I usually use a reference mark of approximately 8 centimetres superior to my incision, and that usually corresponds with the anterior superior iliac spine. And it's pretty consistent marking, as David says, that the umbilicus is in a pretty similar place in all people. And then I'll defat right down to the dermis, and then I'll use 2 silk sutures to bring it down onto the abdominal wall, and it gives them a nice divot, and that doesn't rise up if you use permanent suture. And if you use silk, it's soft so they can't feel it, and it gives them a nice, relatively problem-free punctuation point in their abdomen.
Silk is interesting because it tends to cause sinuses. I mean,
can I just come back onto this point? So, Kellee, you saying that you basically just plicate from beneath the skin and bring it down as a sort of...
Yes.
Right, okay. So I'm very interested to hear this because in my experience, they never last. And...
No, they didn't last when I was using absorbable suture, but they do now with the silk pulled down for the most part. I get some that rise up. Again, the patients never, my group of patients don't tend to worry about it, I have to say.
But if you were doing this operation on a postpartum abdomen in a young, obviously where the aesthetic is important, that wouldn't be my preferred choice of repairing it, I have to say.
Well, I always discuss with them the risks and benefits of the both, and I will do an umbilical reimplantation if they are desperate for it, but most of them, their umbilicus is very deformed, and we discuss it do they want a scar there or not want a scar there, and I'll just listen to what they want to do.
You can actually place the scar within the umbilicus, and that's one of the little refinements, but still the small risk remains of stenosis, but it's...
What are the reasons that plastic surgeons don't use mesh for fascial protection where general surgeons might do so? And why do you do what you do differently?
That's a great question. Why do all surgeons do things differently? Partly because of organic development, partly because of empiricism. And then once in a while you collide with a bit of peer-reviewed evidence and you think, oh my gosh, I better rethink that. So I'll give you a classic example of that, Roshan. Okay, let's just go back to the umbilicus, okay? So when we were writing the EHS guidelines on diastasis, there were 9 of us, and we went through all of the literature to review this. And there was clearly a really huge lack of literature to guide whether mesh should be applied, for example, in the management of diastasis or not. The problem is then you have to draw upon empiricism, and you have to draw upon the fact that, for example, in this particular instance, there is literally a century's worth of plastic surgical literature, which is attenuated to the role of simply just using application to address the diastasis. For example, when you are dealing with an overt hernia, the evidence would suggest that having reduced the hernia, you need to reinforce it for a period of time with some mesh. If you go back to obviously the classical papers of Yeakles and Co. But in fact, even that data is now open to question. And actually, Tom Henneford gives this fantastic lecture on what he describes as research fragility. Because specifically, if you think about the Kaplan-Meier curves that we used in Yeakles' 2 papers, initially in the New England Journal of Medicine and then in the American Journal of Surgery, these 2 papers and those 2 graphs are amongst probably the most quoted graphs of all time. That a simple suture repair of a hernia had a higher recurrence rate than those using mesh support. And of course, not only did it affect our practice, but of course it has spawned a multi-billion-dollar industry. Some of the statistical analysis, some of the subset analysis of those papers would suggest that actually the follow-up only brought in about 60% of the patients who were initially studied, and that actually the difference between having a statistical and a non-statistical result was not in the order of many, many patients, but actually was in the order of 2 patients. So in answering your question, why we use a mesh and why we don't, the answer is that it will invariably depend on your decision making at the time. So in my postpartum patient, and in fact I'm just submitting this for publication now, I've never used a mesh, and I've got just under 700 patients worth of follow-up to show that that has worked well in terms of durability, function, long-term aesthetic outcome. There may be an application of mesh in reinforcement, the exact term that you use, Roshan, aesthetically, and particularly in one part of the abdomen, which is in the epigastrium, because the epigastrium is an important area aesthetically, and as you know, it's a site of 80% of incisional hernias. Now, why? Because clearly it must be an anatomical vulnerable point, a weak area. And there are a number of reasons. If you look at the structure of the anterior abdominal wall, why that may be the case. For example, below the umbilicus, the rectus fascia is suspended between the 2 wings of the pelvis, and so it remains relatively taut. But above the umbilicus, the myofascial envelope is much more expansile. It's attached to the subcostal margin. It has to cope with expansion due to breathing. And as you well know, when you see patients following abdominoplasty, one of the things that they develop is a paradoxical bulge in the epigastrium because of the fact that this area is much more attenuated. And I take you back to this point about panfascial attenuation. So there may be a role in using mesh in that group of patients. And I've been using a synthetic resorbable mesh now for the last 3 years with very good long-term results to 3 years. If you're talking about using mesh in the conventional sense where you've got a recurrent hernia, then I will always look to use a retrorectus or, if necessary, sublay mesh. There's not much of a peritoneum there. So I will use a mesh just as regularly as my general surgical colleagues. And through the course of the education that I've received through the abdominal wall meetings this last decade and all the others that I've attended to, I've started and continue to think about the type of mesh I use, where I use it, how I use it. I'm much less likely to use an onlay mesh than I would have done 10 years ago. I'm much more likely to use a retrorectus mesh. Specifically in the postpartum patients, I will not use any form of mesh apart from an aesthetic reinforcement in the upper part of the abdomen. I don't believe in using it in the retrorectus position because patients feel it. There's no question they feel it.
I was just keen to understand whether those 700 patients that you're talking about and you're talking about the suture closure refers to primary and incisional hernias or purely to postpartum diastasis?
They're postpartum diastasis. The incisional hernias are a separate group. And in that group of patients, Ram, and thank you for asking me to clarify that, I will almost invariably use a supportive mesh. Now, of course, what's been interesting is the introduction of Greg Demanian's mesh suture, which I think is going to raise a whole other set of questions, particularly in the small incisional hernia. So in my umbilical hernias, I would use this mesh suture. I don't know if that's available to you in Australia.
No, it isn't available here. Apparently it's coming.
Well, I have to say, I would just say to you, colleagues, I would welcome it. I've been using it now since 2021. I use it in all of my abdominal repairs, and the ability of this mesh suture to distribute tension across fascia, particularly if it's been pre-operated on where there's a tendency to develop cuts in the fascia, is very different in its behavior from a monofilament. So there's going to be another application. And if you get a chance, look up Greg's paper from 2015 where he describes using polypropylene strips. So if you take a sheet of 30 by 30 simple soft polypropylene and you can cut it into 2 centimeter or 30 by 20 and you cut it into 2 centimeter wide strips, and you can then pass those strips through the medial edge of the rectus and then tie the mesh as a suture. This was written out, and I adopted this technique in my component separation patients. And Greg then made the natural next step, which was to actually tube the mesh and shank it to a needle. And that is what Duramesh is. And I think we're now going to see another small but very sensible tool whereby you may not feel you need to use a mesh, but whereby you may use this mesh suture. And it's so far proven to be very interesting. And in small hernias, I may elect not to use a supporting mesh. So I would hope, Roshan, we is evidence-driven as our general surgeon colleagues.
Yeah, because when you spoke of evidence, and I'm not sure I heard you right, but were you talking about the Leeuwenhoek paper in NEJM in 2004, suture repair versus mesh repair? That was the big thing. Yeah. So that was for hernias, not for diastasis. So just so that people don't get confused between the two elements. So, moving on, Kellee, you handle these complex abdominal wall patients, and now there is an increasing awareness about the needs to give the best possible outcomes, because in spite of the surgeon doing the very best, outcomes can be dismal or even shocking. As an experienced surgeon, what few things would you say are what the rest of the general surgical community should be looking at in order to improve outcomes? Should it be technique focused, or should it be that they need to learn X procedure, or what things would you basically say are important in this particular respect?
I think those of us who do these complex hernias sit in our clinics often dismayed at what some of these patients have been through when they've gone through 5 to 6 hernia repairs, and looking at the notes of our colleagues who may do hernias once a month, once every 3 months. And we're on a real campaign now to think about that first operation should be the best operation and the only operation these patients should go through. And I think the tide is hopefully slowly changing with our colleagues, but as more and more of them call us up and ask for help, because I don't think that there'd been a lot of thinking around hernia until this recent revolution in abdominal wall. But so we're hopefully going to be starting a campaign soon with the simple words of stop and think when you see your hernia patient. And the things I tell my staff to think about is always think about why this hernia has occurred, because I'm not sure when I trained that I ever thought that this was anything other than a hole to be closed. But there's always a reason why these hernias occur. And the most common, obviously, is obesity in our society now. But does this patient have an underlying cancer? How do their bowels work? Do they have an apron down to their knees that's pulling their abdominal wall? Have they got 5 children that they carried high and pushed their diastasis out? Do they have multiple scars? So why did this hernia happen? My juniors always are very mystified when I ask this, but there is always a reason. I CT scan every single patient looking for this reason, and you find it in a large number of them to be more than just obesity. So that's the first thing. I wish my colleagues would just stop and think. And then the second part of stopping and thinking is that, are they the best person to fix this patient? And do they understand the principles of what is going on? Do they understand their comorbidities? And should they be asking for advice in one of the many multidisciplinary groups that are starting to spring up around the country? And so that's very exciting for all of us who live in hernia world to have people asking these questions. And then the third part of when I see these patients, apart from the prehabilitation, which gets covered very well in every hernia meeting, is that thinking about hernia prophylaxis in our general surgical patients. And we're all very excited to fix the pathology that we're dealing with, but no one is thinking about the closure. And frequently, the most junior staff are left to close the abdomen, the consultant surgeons leave, and closing time is not coffee time, as we all say in our operating theatre. The most senior person needs to be scrubbed to the very end of the case, and you need to think about, does this patient need prophylactic hernia repair, which I have no hesitation in doing. The other part of that is that in surgery outside of general surgery, so in vascular, in urology, they're not being taught open surgery anymore for the most part. And so they don't know how to close abdomens anymore. And I have no hesitation. I call myself the closer in our hospital, and I have no problem with them calling me to ask me advice on how to close an abdomen or to close it for them, because we don't think about what we're setting up these patients for the next 10, 20, 30 years of their life. And that could be more important than the operation they've just had done.
Let me specifically ask you, vis-a-vis obesity, which happens to be your particular area of work in the abdominal wall, what things would you be very focused on to improve outcomes, especially considering that you're doing open surgery for all your cases, right? So it becomes very important not to have flap necrosis and wound infections and seromas and hematomas, etc. So you have these typical 100+ kilo patients who have come with primary or an incisional hernia, and you need to give the best possible outcomes. And what exactly do you do? We all tell people to lose weight, and that's about it. Very few people go beyond it. What special or extra things do you do?
So we go on the journey in our clinic, it's called, and my juniors all know what the journey is. And in fact, it's just a thing we write in the chart now. The juniors come in. So typically I would suggest only about 10% of patients who come to my clinic are ready to go at that first consultation. And I often start, even before the patient comes, I'll send out information on what my expectations are going to be when they come to that clinic. And we talk about weight loss in that literature that I send out to them before they even come. So they're a little bit primed for what we're going to be saying. So you get over that, what could be sometimes an angry patient when they're first discussing weight loss. So the other interesting thing is that a lot of their chat groups that they're on, they already know what we're going to say, and they say, don't go and see her until you started trying to lose some weight. So we do that, and then when they come, I mean, the GLP-1 agonists have just been a revelation to us. Often now, again, through social media and social networks, patients are already on them, or who have a brother or a sister who's been on them, who's been successful in losing weight. And so there's almost no one who says no to going on them. And I write scripts for anybody who is not already on. And then it's a lot of counselling for them. And so we start the journey, and that means that I see them every 3 months. And I'm their cheerleader, essentially. I just say to them, I will help you, and I'm going to help you. It might take 2 years. Every time, we're going to get there. And I think at least 90% of them do. And I even have patients come back who sometimes are tough nuts to understand weight loss. And sometimes I don't see them again, and I think, oh, well, I haven't got the message across there. But they'll come back 5 years later and 30 kilos lighter and said, I did it. And that's so exciting when they and I say, well, you're ready to go, and I'm so proud of you. So there's just lots of support, lots of hugs, lots of cheering, and we get them there. And I know I sort of aim for a BMI under 40, and there we go. Yeah.
So do you have a dietitian who handles the patient along with you, or do they have to figure it out for themselves? And the other thing is, many of these patients have severe osteoarthritis and maybe on a wheelchair, and they're not really your best candidates to say, go and walk 10,000 steps. How do you handle these patients?
In public, no, I don't yet have a dietitian, but I do tell patients, most patients in Australia have access to free 5 visits with a dietitian for free. And so I do strongly recommend that they take that up. And I think we're very lucky that the GLP-1 agonists help people make healthy choices. I also give them literature about healthy choices, and we have discussions about that. There is a group of patients, I use bariatric surgery in the patients who have significant amounts of weight to lose. So if someone has 50 kilos to lose, I strongly recommend they have bariatric surgery. And, they're usually then ready to go within 6 months of having their bariatric surgery. And luckily in the hernia cohort, it's often the stomach is the only thing in the abdomen. So bariatric surgery is actually quite straightforward in many hernia patients. So again, it's that in Australia, unless you have top health insurance, that's difficult for patients to access. But we beg and plead with our public administrators, and we get some cases through and get them there. But I'm pretty driven about the weight loss because it makes the surgery easy peasy.
Can I just come in on that? Because I think Kellee's illustrated something that's really important. It tracks multiple bits of wisdom that I hope when people are reviewing her summary there. I mean, patient selection is at the heart of this. And, it is about patient selection and about, Kellee talks about stop and think. In the UK, we have a thing called get it right first time. The fact is, the assessment to get your patient to that stage has to depend on, if you can, a multidisciplinary management. And we have a number of multidisciplinary meetings which patients can be submitted to. This is very good in collectively being able to establish what's right for the patient. And the weight optimization is so important because as surgeons, there's a sort of pressure that somehow we must come up with a solution. But that solution doesn't have to be surgical in the first instance. And very often it is, exactly as Kellee said, about nurturing those patients on a journey that may take quite a long time. but the patients are very motivated. And particularly if you're dealing with a patient, for example, who I can think of 2 classical patients, both who ended up with Hartmann's, laparoscopy, skin grafts of the abdomen, functionally and aesthetically hugely debilitated. So the driver for them to lose weight, because of course their complications were made ever so because of their weight, are very significant. And you take that patient on the journey, but you don't step in any earlier unless you feel absolutely happy to do so. And that's about optimizing the patients in all regards. And by working in a multidisciplinary team, hopefully you can draw upon your bariatric colleagues, your dietetic colleagues, your physiotherapists, so on and so forth, to be able to just get those patients into the best possible state before you offer them surgery. And this scenario that Kellee pointed out about patients having multiple procedures before they come to see you, hopefully with the introduction of MDMs, the awareness of hernias, hernia centres, we'll begin to, we'll start to see the decline of that.
Another interesting aspect to this, which I haven't really encountered much, even though I've been in bariatric surgery since 2003. It was recently that I encountered it in 2 patients in the same month. They came with hernias, easily around 120 ballpark weight. When I mentioned that the weight is going to have to be addressed first, both of them, they were unrelated, different times. Both of them were actually almost insulted about the fact that I raised weight, and it's as if I did something which was quite rude, though my demeanor or my language was far from rude. It is a fact that if you bring weight loss into the conversation with somebody who is not willing to go down that path, it makes your job as an abdominal wall surgeon pretty hard. And then you kind of don't know what to do. At least I didn't have the answers because I don't have that particular scenario in the past to back me up. So just keen to understand how you would handle a situation like that.
Yes, there are some nuts that are very tough to crack. But the vast majority of overweight patients know they're overweight, and it's just bubbling under the surface, their admission of it. So usually, but yes, there is this group that will be very insulted, but that's that group that I said, sometimes they go away and they have a revelation, or that when they've had time to reflect on it and think about it and know that I'm not there to insult them. But sometimes you will just insult people. And I just say, I'm here to get the best outcome for you. And I know that is by being smaller, and that you've had 5 operations before and they've recurred. They've all not been technical failures. So we have to do something different this time. And so I say that a lot. I have a series of pictures that I show of my previous patients on the weight loss journey and just show them the difference in the profiles of the patients and how much it changes the amount of things that we've got to put back into people's abdomens. I show those sort of pictures. So you've just got to try and find the right angle and keep trying. I also say to people a lot that we've thrown away this idea, it's just not eat less and exercise more, because it is so much more complicated than that. And it's not people's fault that they're overweight. And I think saying those words sometimes helps win over people, just to say that, you just can't do this without help, because people have failed their whole life to lose weight. And it shocks me the number of our colleagues and general practitioners who still think weight loss is willpower, because it's not. You win over most people if you show a real understanding as to how weight loss works.
Yeah, I think that taking the blame out of the discussion is very important right at the start. And as Kellee embodied beautifully, you're taking the patient on a journey. You're with them on that journey. You're part of the solution, not the challenge. And they don't have to leap over you to be able to get where they want to be. And explaining the rationale behind what you're trying to achieve with them is so important. And I suspect, and again, Kellee alluded to this, by the time patients come to see us, they often have had the misfortune of several previous procedures and have had probably a miserable time with prolonged wound healing. They may not have, for example, had a vac pump on a wound for months and been debilitated at home. And so by the time they come to see us, hopefully they're in a slightly more open-minded place. It's unusual. Interestingly, Ram, I see that situation, but not so much in the primary hernias, but there are other pathologies that I see where patients are quite understandably sensitive about weight, but where weight loss may be an important first step to giving them an optimum result. But Kelly's absolutely right. You have to take these patients on a journey. You can't simply impose something, and you need to accept they're going to feel upset generally about their state as it is.
I just wanted to add, can I just say abdominal wall is leading the way in this prehabilitation thing. And I always bring up, especially in our mortality meetings, when my colorectal surgeon colleagues and my hepatobiliary surgeon colleagues have taken patients to the operating room with BMIs of 50 for relatively non-aggressive cancers or benign things. And there's been no thought to prehabilitation, and yet they blamed the patient's weight or the complications. There is no excuse to not get these patients ready for surgery in all realms of general surgery now.
And I think this raises a fascinating other aspect, because, of course, Ron, as you know, as a robotic surgeon, robotics have allowed you to consider operating on a group of patients you wouldn't have operated on beforehand. And so I think one of the things that's going to be interesting in the next decade is seeing whether we've simply moved our complication curve to the right. In other words, in being able to offer some form of intervention to patients that you wouldn't have in the open situation. You might address their cancer, for example, which is really important and noble, and not open the abdomen, which is great value. But in the process, have we come across another range of problems? So I think particularly in the hernia scenario, I don't know how much of a service we're going to be doing in repairing hernias in patients who happen to be physically much larger. And that's not me questioning. I'm just saying I wait to see I'll be interested to see what happens in the medium term.
It's a complete different field. I mean, I could spend a considerable amount of time talking about the evidence aspects of this particular issue that you raised, but to make it very brief, our Danish friends have gone through the Danish hernia database. This was led by Christian Jensen, and Mette Vion was part of this study. They found that when you do robotic surgery, BMI doesn't matter when it comes to repairing hernias. So the outcomes are not adversely affected if you're doing robotic surgery. And the same was true for smokers as well. That is one aspect of it. And the other aspect of it is counter, which could be that maybe you're talking about patients whose BMIs are ranging between 35 and 45. But whenever you talk of patient with a BMI 55 or a BMI 60, are you talking about the same patient? I mean, it's a different ballgame altogether. So the last word hasn't been said. The class of obesity significantly matters.
Ram, I just wanted to add, I get a bit upset about when people talk about doing minimally invasive because the patient's obese. And I think as doctors, and especially as hernia surgeons, we need to be very holistic about our patients. The hernia is just the cherry on top of the sundae and of what's wrong with our patients. I don't take the argument of, because they're overweight, we should be doing minimally invasive surgery. I think we need to make our whole patient better, so we fix their whole body, not just the hole in their abdomen. And that's what I worry about. Minimally invasive surgery is all about patching a hole, not fixing a person.
Looks like we need to have an open versus robotic heated debate to counter some of the overtly inflammatory things that Kellee and you have been saying.
No, I'm not. It's not against robot surgery. It's about let's use the robot because they're overweight. I think that is not a good argument.
Yeah, I think it's really important. I don't think neither Kellee nor I are averse to the robot at all. And in fact, when you see the beauty of that surgery and you see exactly how it's conducted, you can't help but be in awe of it. But I just think, such a fundamental part about the success of hernia surgery is careful assessment of prehabilitation. This is what I'm saying. I think if you were to look at the techniques available to us a decade ago, broadly speaking, to now, they haven't changed. And in fact, we've started to modify, for example, our mesh uses, but fundamentally, the procedures haven't changed. What has changed is our selection of the patients. And we've simply, and importantly, moved the focus left. And we're starting to say, well, actually, what can we do about the patient themselves to bring them to the operation theatre, to have that same operation with a safer and better outcome? And of course, at the meantime, you do have other techniques which will be able to obviate some of those risks. But how much do you use them? And obviously, that's your field, Ron. But, I think prehabilitation is such a crucial part of these patients in all of its totality, as Kellee says, seeing the patient holistically.
While we stay on this subject, It just occurred to me while you were talking. Obviously, sensitive communication is involved in counselling people about their weight preoperatively, particularly when you're considering prehabilitation optimization. But how does that compare with the conversations you have with your smoking patients? What's more difficult?
We're in a relatively fortunate position in Australia where smoking rates are very low because you're a social pariah and very poor if you smoke here. I'm very hard-headed about, and I approach it the same way. I usually just tell them it's just dumb. Usually I use the financial argument to them. Just think how much money you'll save. And usually I try and recruit the relatives. There's usually a non-smoking relative who's on their back. I think I, again, am pretty successful with trying to get them to stop at least a month before and to try and quit if they can. And just use the same arguments. Just say, can you do it for me? Can you do it for me? Can you do it to your family?
David?
Yeah, here we do good literature support to show the impact of smoking on wound healing. It's very interesting. There is a cultural element to this. If you're in Australia or if you're in the UK or in Western Europe, as a general rule, you would counsel your patient against smoking. And I personally will not operate on patients who have been smoking, and I have a 6-week cut-off. And I say to them, you have to stop smoking for 6 weeks beforehand. You have to stop smoking 6 weeks afterwards. Once you're healed, it's entirely up to you. If we don't get your wound healed the first time, you're going to have problems. Smoking is really an absolute no-no, and particularly, for example, if we're doing facial work, where the flaps are much thinner, and of course the potential complications are much more visible. You have a group of patients who, culturally again, so if we, for example, see patients from Latin America, the Middle East, very high rates of smoking, very high rates of smoking. I have a cohort of patients who come in from the Middle East who will smoke at least 40 cigarettes a day. I don't know whether they've got the time to smoke 40 cigarettes a day, but will smoke 2 packets of cigarettes a day. When you talk with that patient group about giving up smoking, some will endeavour very hard. Some will cut down and get down to sort of 10 cigarettes a day. And you have to weigh up the risks versus the benefits. And it's not a sort of self-righteous journey. You have to think, what are the risks, what are the benefits, and what can you do to modify and moderate your surgical technique in that situation? I recall a young man from Qatar who smoked 60 cigarettes a day. He had lost 80 kilos as a consequence of bariatric surgery. Had a surprisingly, because he was young, had a surprisingly modest pelvis. But basically, having gone through hypnotherapy, nicotine patches, I got him down from 60 cigarettes to about 59. And in the process, recognized, he was deserving. But I said to him, look, we do this, these are your risks. Because he could not see any way he was going to give up. Where this story is going to is, first of all, I don't operate on the smokers and death, and I can only literally put up this one case. But in his case, I excised the skin, I absolutely undermined it minimally, and I put on a preventer dressing. To my surprise and relief, nothing happened. But the key to that was the fact that I ended up not doing the operation I would routinely do, which was actually absolute minimum undermining and using a preventer. But as a general rule, I don't operate on them.
So when it now comes to raising skin flaps, proper plastic surgery question for general surgeons watching us, what are the ways in which one should raise a skin flap while fixing a lower abdominal hernia, for example, or a hernia with a diastasis, to avoid getting skin flap necrosis or collections or infections, etc., adverse wound events, especially when patient wants the pannus removed?
Let's think about those in 2 different patient groups. Well, so first of all, let's think about the patient who has a relatively normal body habitus and is a non-diabetic, non-obese, non-smoker. In that patient group, there are some simple basic tenets of surgical practice which you'll be very familiar with. So, for example, you will raise your flaps, relatively thick flaps that will go down onto the rectus fascia. And where you see perforators coming through the rectus fascia, vertically up into the overlying fat, where you can, try and preserve them. We know there's good data to show that where we preserve the perforators, we preserve vascularity of the skin edge, and with it, we reduce healing issues. But in the patients who've been operated on multiple previous times, usually those perforators are gone. So in that instance, you go back to very simple rules. You try to elevate your flaps as minimally as possible to be able to access your surgical field. Crucially, you close without tension, and that's very important. Some people will close the dead space off using quilting sutures. Some people, like myself, the dinosaurs, will still use drains. It's important to remember that drains do not prevent seromas, and neither do binders. And quilting, I think, slightly controversial, not in terms of its aim, but in terms of whether it affects seromas or not. But the simple things of tension-free closure, avoiding dividing perforators where you can. So, for example, if you're doing a midline, a classic, for example, anterior component separation, where you open the skin, you're elevating your flaps laterally, medially, you're raising the level of the rectus fascia. As you come past the umbilicus, you'll start to see quite large vascular perforators. And you can dissect around those and use a minimally invasive technique, a minimal access technique like Chuck Butler described, which is my routine go-to for an anterior component separation. So just above the umbilicus, you can make a tunnel, avoiding the perforators, so you get to the lateral edge of the rectus, and then you can make your vertical incision in the anterior rectus fascia and release your rectus fascia. And in that way, you maintain vascular perfusion to your skin edge.
But then how do you manage to close the midline in the diastasis? If you have to go laterally and you leave the vascular perforators around the umbilicus in the middle.
If you're talking about your component separation patient, for example.
No, even if you just talk in terms of diastasis and umbilical hernia.
Well, it depends on how much. So you will usually have several rows of perforators. They won't be the only perforators, but you have two particularly rich perforators sitting just to the outside and the north of the umbilicus. The vascular architecture of the perforators of the abdomen vary, but as a general rule, you will have medial row and you may have a lateral row. The medial row may have been taken out by prior surgery, in which case then it's incumbent upon you to just be a little bit more careful as you approach the edge of the rectus, the lateral edge of the rectus, because you will come across these perforators. So you try to spare them when you can. If they've been taken and you can't spare them, then it's about trying to avoid wide dissection and wide elevation of the flap, particularly if you're dealing with patients who have a prior history of diabetes or who've had a prior history of smoking. Once you close your diastasis, of course, you are bringing your abdominal wall closer together, and in so doing, you'll be bringing your skin flaps closer together. So it doesn't necessarily mean that closing the diastasis works against you. It may actually work for you.
You both are very assertively open surgeons, but if you had to have surgery done for, say, an umbilical hernia and or a groin hernia, what approach would you want for yourself? Or would you just leave it to the surgeon?
In my opinion, there's no such thing as just an umbilical hernia. It's always a bigger problem than that. The only people who get true tiny umbilical hernias are athletes, perhaps, who BMIs 22, have a simple congenital umbilical hernia. The rest of us have either postpartum hernia with diastasis, they have male hernia with diastasis, they have liver disease, they have fatty liver disease. So it's not just an umbilical hernia. So I would like the surgeon to fully assess my abdominal wall and fix the hernia in the correct way, usually by reinforcing the entire retrorectus space. So that's my complex answer to umbilical hernia. It's never simple. For an inguinal hernia, if I had a simple inguinal hernia, I would have an open repair every day of the week for an inguinal.
Even for a reach stopper or a retrorectus approach, you would want an open approach.
Yeah, because I'd want my skin sorted out.
I have to say, so that answer can't be improved upon. But Rama, I have to ask you, you see, there is an increasing body of literature, is there not, about concerns about intra-abdominal mesh. So I know the IPOM's kind of coming in, going out, coming in, going out. That's not my field. But I would feel philosophically concerned about an intra-abdominal procedure for a superficial problem. And Kellee hits the nail on the head. You know, you've got to assess exactly what's causing your umbilicus. There was a fantastic paper written in 2016 by a German group where they said, and the title, perfect, they said that umbilical and supraumbilical hernias are a risk factor for diastasis, instead of it being the other way round, because of course they, as a general rule, will not occur in the absence of a diastasis. That accurate diagnosis comes at the heart of it. But with regards to open, I'm led by Professor Slater. I would take her advice on that. There certainly seems to be, beautiful results with robotic hernia repairs, and there certainly seems to be great results with open repairs. So you take your choice.
Perhaps we should ask Professor Ram to answer his own question.
Well, definitely my colleague is an expert laparoscopic surgeon. I would prefer that. Or if he is comfortable with the robot, I would prefer that all day. Unless there is a definite reason for me to go the open approach. These issues, I would certainly want MIS because I would also want to start work maybe in 48 hours max, if not 24. Our guests will say that all our patients will join work anyways in 48 hours or so.
What would you look like after RAM?
Well, at least at this age, nobody gives a shit. Regarding the abdominal wall, especially the kind of stuff that people like you may deal with, do you find that there are many patients who develop complex abdominal wall problems after they have had their rectus abdominis muscles shifted over to the chest for breast reconstruction after mastectomy or maybe radionecrosis? I don't know. Must be a very, very rare thing. When I used to be a junior house officer, used to see loads of these radionecrosis of the chest wall for breast cancer. And I've even seen, necrosis going all the way. I could see the beating heart and the lungs. It was all kinds of ghastly stories from prehistoric times. Anyhow, so what do you think about the TRAM flap, its current role in reconstructive surgery and the abdominal wall in that context, Dave?
Okay, so if we think about the TRAM flap, just for the audience, remember we're talking about what we call autonomous reconstruction. So this is reconstruction where we're reconstructing and replacing the skin and the volume of the breast with the patient's own tissue. And when this technique was popularized by Hartran and Scheffler and published in the early 1980s, that used what was called a pedicle TRAM technique, whereby you took a transverse pedicle of skin from beneath the umbilicus and you elevated it via a pedicle that consisted of whole rectus on the contralateral side. So you could pedicle up the abdominal skin. And of course, this created a fairly significant defect, vertical incision, loss of rectus, which was then placated together. And those patients developed what we call TRAM site hernias, donor site hernias. Now, it has to be said, with reinforcement, patient selection, if you were lucky enough to have a patient who were able to achieve a closure of the abdomen without too much tension, that the incidence of hernia formation in that patient was actually remarkably low. They would have had functional issues, of course, with the loss of the rectus, but it was all about risk versus benefit. There is a huge body from the 80s and 90s, beautiful reconstruction. The technique then evolved to what was called a free TRAM, whereby you didn't elevate the whole of the TRAM, you just took out a sort of segment of TRAM muscle, which was fed by the deep inferior epigastric vessels, and now you are only patching a small area of rectus fascia, no more than the sort of 5 by 8 centimeters. However, you had lost the full width of the rectus muscle. So again, still an incidence of herniation due to a defect. As we began to understand the vascular supply of the recti, which consists of vertical perforators coming off the deep inferior epigastric, surgeons, and principally Philip Blondel in Belgium, advocated isolating those pedicles, isolating those perforators, and harvesting literally the skin flap with its underlying fat and simply the perforators. So the only defect in the rectus fascia were the small rents that were made to be able to isolate the vertical perforators and to be able to disconnect the deep inferior epigastric from its origin at the iliac. For the last 20 years, these are called DX flaps, deep inferior epigastric perforated flaps. And what that does is it allows you to harvest the whole of your skin paddle, but without taking any very little muscle. You might need to take a little cup, depending on the anatomy of it. So as a consequence of this, the damage to the recti were very, very much less, and the incidence of hernias were very much less. But they were not zero. And that's for two reasons. There are, unfortunately, a group of patients that when you harvest the deep inferior epigastric vessel, you devascularize the rectus muscle. And secondly, there are another group of patients that in elevating the skin flap, you may denervate it. And so you end up with rectus muscle atrophy, despite the fact that you've done a high technically skilled dissection of the anterior abdominal wall. You can use preoperative angiography, an MRI, an MRA, or a CTA to be able to show you exactly where the perforators are to further reduce your incidence of soft tissue injury to the abdominal wall. And you'll be glad to know, Rama, that people are even advocating the use of robotics, and it's already been described, to harvest flaps from within the abdomen. So you can get within the abdomen, see the deep inferior epigastric vessels, and dissect the flap from behind. So very elegant, and again, the aim being to minimize that risk. But there are nevertheless, even in those very conservatively oriented flaps, a group of patients, and a very, very small group of patients, has to be said, who may be unfortunate enough to lose function on that side, either as a consequence of denervation or devascularization. And they present an interesting challenge because those patients will tend to present with a bulge rather than a formal hernia. The TRAM group of patients develop a formal hernia because they've got a defect which may have attenuated and stretched. But the DIET patients tend to present almost like the post-transplant patients that Kellee will deal with, that where you're actually looking at a range of denervation injuries as well. But they're a small group, it has to be said. They're a much smaller group than they were.
Vis-a-vis flaps, do you have significant occasion to provide flaps like the anterolateral thigh flap is now one of the more popular ones in AbWall? Any other flaps to provide skin cover, and what are those situations like? Because most surgeons wouldn't really have occasion to think in terms of providing skin cover or skin and soft tissue cover. What are the situations where you encounter patients who need these flap procedures apart from maybe mesh and whatever other reconstructive techniques that you would use?
Yeah. So there are two main indications, Ron. First of all, in the patient who undergoes large cancer extirpation. Okay, so that may be skin cancer. So we've got a body of these patients who have got wide excisions, which are through and through with exposure in the underlying heart, lungs, gift tumors, where we've got large excisions where they've had cutaneous deposits, squamous cell carcinomas, and those patients with locally progressive adenocarcinomas of the gut. So where you've had to undertake wide through and through thickness of the full thickness of the abdominal wall, you need to replace cover. So that's the first group of patients. The second group of patients are those with intestinal failure. So they're patients who've got multiple fistulation, they've had multiple procedures, and there's very little left of the abdominal wall, and they've got a short gut syndrome. In those group of patients, you have two options. The first is that you're able to excise into your abdominal wall. They can have some form of anastomosis, and they're then going to be parenterally fed, and you resurface the abdomen, and these are quite very significant defects. And a very small group of those patients will become eligible for transplantation. As you correctly said, the anterolateral thigh flap is in many respects our workhorse flap for these patients, because they allow us to provide full thickness reconstruction and resurfacing the anterior abdominal wall for very large defects. And of course, you can raise both thighs to reconstruct and resurface really extensive, almost full width defects of the abdomen, because you can take your flap almost from groin down to just above the knee, very wide. So you may end up applying a skin graft to cover your donor site. Very often you don't, surprisingly, but skin graft to cover your donor site on the thigh. You can elevate the flap up on your pedicle, which consists of these little branches of the lateral circumfemoral vessels. You can, and then tunnel your flap to resurface your abdominal wall. Along with that flap, you can take some tensor fascia lata, which provides you with further support. In our hands, we have tended not to use meshes, although with some of these bigger defects, we will use a biologic. Chuck Butler's papers would suggest, experience would suggest you always need to use a mesh. We haven't always, and thankfully they haven't been troubled with herniation to any notable extent. But the anterolateral flap is hugely valuable. But when you're dealing with supraumbilical defects, then your pedicle may not work, and you may have to disconnect the pedicle and then transfer that flap as a free flap. So you may transfer it onto the gastroepiploic vessels, which is very pleasing because they're literally sitting there, but the veins tend to be very fragile. Or you tunnel up into the chest and you take down the internal mammary vessels, and they're a very useful form of anastomosis. And that's, again, very feasible. That allows you to resurface large upper abdominal defects. So it's a very, very useful form of soft tissue. And it's a very commonly used flap in the plastic surgical world because it's thin, it's pliable, and it needs a very good donor site.
I have a bunch of other questions, but this won't end. The night is short and your day is long day. We've had a fantastic conversation, and you people have been very generous with your opinions and your insights. And I'm sure many people will find it pretty not only useful, but captivating in many ways as well. So from my side, thank you very much for sure.
Yeah, so many lessons to be learned, many more coming your way in episode 6. Our sincere thanks to our guests, Professor Slater and David Ross, and again to you, Ron. Please don't forget to like and subscribe and to share with all your AWI enthusiastic colleagues. We look forward to seeing you on the next episode. Thank you for watching the vodcast, and please look out for the next episode. The Hernia Hub team welcomes all comments and feedback and invites you to share these via our email address, herniahub@gmail.com.